Hello everyone, this is Dr. Vishal Gawali, and it's my huge pleasure and honor to be speaking at the Presidential Symposium of the 2020 ASTRO annual meeting, and I'd like to thank the organizers committee for both giving global oncology such a huge priority by making the theme of the annual meeting in 2020, as well as giving me the opportunity to speak about something that's very close to my heart. It's about cancer grounds at the need for prioritization in global oncology. These are my disclosures. The learning objectives for today's talk would be to understand the concept of cancer groundset and to understand what the academic career of a global oncology would look like and how you can contribute to it no matter where you practice. As a medical oncologist in a high-income country, it's actually our privilege that we debate about whether or not to use a drug like this that improves median survival by less than 0.3 months, when in reality, most of the patients with cancer in the world are dying due to lack of access to curative services. For example, this data from the Lancet Oncology Commission shows that by 2030, annually 45 million cancer surgical procedures will be required in 17.3 million cancer patients, of which 10 million will be from low and middle income countries, but less than 25% of these patients will be able to afford safe, affordable, or timely surgery. And we talk about low and middle income countries not being able to afford cancer surgeries, but the reality is that we cannot afford not to invest in cancer surgeries because by 2030 alone, this lack of access to cancer surgeries will lead to a loss of 6.2 trillion US dollars. The situation with radiotherapy is not very optimistic either. More than 50% of patients from low and middle income countries do not have access to this treatment. And if we look at low income countries alone, that's more than 90% of the patients not having access to radiotherapy services. When I first saw this news in BBC, it broke my heart. The title says, "Do US dogs have better access to radiotherapy than Nigerian people?" Of course, this is not against the dogs. This is about the huge disparity in access to curative cancer treatment all over the world. While we have one radiotherapy machine for 1.2 million cats and dogs in the US, for the whole country of Nigeria that has 47 million people, we have only one radiotherapy machine. How could we let this disparity happen? In the West, nowadays we are attracted with the concept of cancer moonshots, including focus on precision medicine, immunotherapy, genetic screening, and we think that these strategies will help us to treat our way out of cancer. We have become so much attracted to the concept of cancer moonshots that nowadays every billionaire or every institution wants to have their own cancer moonshot programs. But the reality is that most of the patients in the world who die of cancer are dying because they lack access to the treatment strategies that we already know to work. So sometimes I feel that we are getting our priorities wrong. If you look at these two articles, both coming from low and middle income countries, and one says about a story about surviving cancer in a country with no radiotherapy machine, whereas the other talks about using artificial intelligence or Watson for oncology for making cancer treatment recommendations, when in fact this modality has not been proven even in high income countries. That leads me to ask the question, does global oncology need artificial intelligence? And my conclusion was that we need a natural common sense more than we need artificial intelligence to solve this problem. This is a map of the world showing mortality rates due to cervical cancer. The redder the country is, the higher the mortality due to cervical cancer. And you'll see that the global south is quite red, including the country where I come from, Nepal, which means that cervical cancer is still one of the top killers among women in this part of the world. However, the reality is that cervical cancer is actually the only cancer where we can talk about elimination. Countries like New Zealand and Australia are already on their way to eliminating this cancer by the next decade. But when we speak with policymakers from my country and other low and middle income countries where this disease is a burden, sometimes I hear people saying lack of access to bevacizumab, a drug that improves median overall survival by nearly 3 months in advanced cervical cancer, as a priority or as a problem. When in fact, the reality is, why should anyone have advanced cervical cancer or anyone die from advanced cervical cancer in the first place? Because we have effective vaccinations, screenings, and we can treat early detected cervical cancer. So that is what I mean by getting our priorities wrong. And that is actually the backbone of Cancer Groundset. Cancer Groundset is a philosophy that focuses on implementing the interventions that we already know to work, implementing the interventions that can be applied globally, in order to save as many lives as possible. So we wrote this paper in the Lancet Oncology titled Cancer Grounds Are Going Global Before Going to the Moon. So I hope I'm able to convince you by now that lack of access is not the only problem in low and middle income countries. Overtreatment or misguided priorities is an often undiscussed but equally important problem in global oncology too. So what do I mean by that? These are two examples from my home country, Nepal. The one on the right in Nepali language says, if you love your mom, give her a mammogram, and at a 50% discount rate, without talking about the risk categories and age categories. And the one on the left also talks about tumor markers at a 50% discount rate as a cancer screening. We all know that tumor markers are not only useless, they are actually harmful. These are not low value but negative value practices. So I had written this paper asking, should low income countries invest in breast cancer screening, and if so, what would be the proper modality? So I guess the bottom line here is that low and middle income countries, as they become more aware of the importance of cancer, they are just trying to copy paste high income countries, and when they are doing so, they are also copy pasting the mistakes made by high income countries. So we need to prioritize our cancer care and research agenda. In terms of cancer care, we need to focus more on curative services, diagnostic facilities, and access to morphine and other palliative care services and supportive care, as well as prioritizing cancer drugs on the basis of evidence and magnitude of benefit, as well as affordability of those drugs. Whereas in terms of cancer research, we need to first focus on developing a cancer registry, because if we don't have cancer registry, we don't know how to measure the disease burden and where to focus our resources on. And then comes studies that assess patient preferences, because until now, patients in low and middle income countries are being treated based on studies from high income countries alone, and we don't actually know what the priorities of our patients are in the local setting. For example, we did this research about financial toxicity in Nepalese patients with acute leukemia, and some of the findings were quite eye-opening. And then comes the issues about pragmatic and common sense clinical trials. Of course, low and middle income countries should participate in clinical trials, but they should participate in clinical trials that focus on the local context and that can be easily implemented once the results are known, rather than participating in a big multinational pharma funded drug trial, after the completion of which patients in that country will never have access to the drug. We discuss about that issue in detail in this paper in Nature Cancer. So finally, coming to the question of how can you contribute, at the outset, I'd like to make it clear that visiting a low and middle income country once a year for 5 days as a tourist is oncotourism. That's not global oncology. So what can you actually do? If you are in a position to donate equipments, please do donate. But when you donate, donate what they need rather than what you don't need. If you are in a position to mentor some trainees from LMICs, do mentor them, but again, teach what they need in the local context rather than what you want to teach. As the Chinese proverb goes, teach how to fish, not provide them with the fish. So the hallmark of an excellent mentor is that her trainees become independent rather than rely on you for their whole life. Provide funding or grants for them, and especially if you are participating in a collaborative research with clinicians in LMICs, do provide them with salary support to protect their time for research, because otherwise they see 200 patients a day for 7 days a week, and it is very difficult for them to have time for research. Give them opportunities, invite them, collaborate on research and trials that are relevant to the local setting, and always do remember that it's a bi-directional learning opportunity. I discussed that point in detail in these two papers. As practitioners in high income countries, there is as much for us to learn from low and middle income countries as we have to offer. And actually, this COVID-19 pandemic has made that apparent, because a lot of the strategies during the pandemic that we employed are actually everyday strategies that clinicians employ in low and middle income countries. Because of the resource constraints, our pandemic times are usual times in low and middle income countries. So in conclusion, low and middle income countries should not make the mistake of copy pasting high income countries. Priority setting is the backbone of cancer grounds. Global oncology is a deeply fulfilling career, but global oncology does not equal to oncotourism. All of us can make an impact. There are various ways to do so, but we should always be mindful that it is a bi-directional learning opportunity. I'd like to thank Astro for making global oncology their theme for the 2020 annual meeting, and I'd like to thank uh, all my global oncology colleagues who have been working tirelessly all over the world. Thank you.